Thank you. So we've got some exciting things going on in the medical school, and one of the most exciting things is we have West Virginia natives, West Virginia students getting highly trained and then coming back to live and practice in West Virginia. And our next speaker, Dr. Philip Aguila, is one of those. Dr. Aguila was born in Oak Hill, West Virginia, went to WVU and got a degree in pharmacy, and then went on to medical school at WVU. Then went and did a residency in internal medicine at Allegheny General Hospital in Pittsburgh, and did his pulmonary and critical care fellowship at University of North Carolina in Chapel Hill. After that, he went to Jacksonville, Florida, and where he was the chief of the section of pulmonary and critical care medicine. And from that position, he was recruited here to Martinsburg to University Healthcare. Dr. Aguila is the director of the intensive care unit at Berkeley Medical Center. He's on the board for University Healthcare Physicians. And I think that he probably is most proud that he was named Teacher of the Year in 2012 by our medical students here. So please join me in welcoming Dr. Philip Aguila.
First of all, I'd like to thank you for coming out on this nice evening. Hopefully, we've seen the end of winter and the beginning of spring. All right. I was asked to speak on the topic of COPD. As a pulmonologist, this is probably the most common disease that I interact with on a daily basis, whether it's at the hospital, in the intensive care unit, and definitely when I see people in my clinic. Before I get to my talk, my outline will include a definition of what COPD and what it encompasses. I want to talk about its prevalence and its effects on healthcare in general. I want to point out how we diagnose it, both by testing and by physical exams. And then I want to touch base on the treatment and the ongoing therapies once COPD is diagnosed. I do want to pick on you all a little bit. Does anyone know what COPD stands for?
Chronic obstructive pulmonary disease.
Great. So COPD stands for chronic obstructive pulmonary disease. But then you ask, what is that, right? Because it's a long term with a short acronym, and sometimes people still have a hard time understanding what is COPD. COPD, as you all stated, stands for chronic obstructive pulmonary disease. It's actually an umbrella term which includes conditions of chronic bronchitis and emphysema. With this disease, there's an impedance in the airflow in the bronchi and the trachea. And those are the main breathing tubes within the airways leading out to the sacs of the lungs. Just a few facts about COPD. It is the fourth leading cause of death in the United States and a major cause of sickness. Currently, it is the fifth leading cause of death worldwide. And that's pretty impressive. It's not just here in the United States, it's everywhere in the world that COPD is quite prevalent. The World Health Organization has actually estimated that in 2030, COPD will become the third leading cause of death. The thing about COPD is that it's both preventable and treatable. This is just a little schematic of that'll help describe what COPD is. Again, COPD includes chronic bronchitis and emphysema. Here, what we're doing here on these little schematics is we're taking a cross-section of the bronchi. The bronchi is what sends the air that we take in down into the lungs. This is what a normal bronchus looks like. The walls of the bronchi are nice and smooth, as you can appreciate there. There is a nice linear pattern in the bronchi. What happens in chronic bronchitis is you see inflammation and structural changes. As you can appreciate here on this cross-section of the airway, this somewhat pink-colored area is the mucosa of the airways. And you can see here, compared to this cross-section of a normal airway, the mucosa is thickened. It is hypertrophied from the constant irritation from the causes of COPD. You also have a narrowing of the airway. You can see the narrowing here compared to here, and this is a big component of what COPD is. The other component of COPD includes emphysema. Again, this is further on down in the lung, further on out into the lung tissue itself. I like to describe the lungs as sacks of balloons where air is exchanged, where we take in oxygen and we expel carbon dioxide. And as most of you all know, balloons expand nicely when you blow air into it, and they deflate when you take the air out. That's what our lungs, these parts here are called the alveoli. This is what they do, is they expand and then they kind of recoil on their own. When you have emphysema, you have destruction and enlargement of these air spaces. So these normally elastic sacs lose their ability to expand. And when they lose their ability to expand, they lose their ability to exchange the oxygen for the carbon dioxide. And that is the main effect of emphysema. So you have, in COPD, narrowing of the airways, and you also have loss of the ability to exchange oxygen for carbon dioxide. More specifically, what international organizations, how they define COPD, it's a disease state characterized by airflow limitations that is not fully reversible. The airflow limitation is usually both progressive and associated with abnormal inflammatory response of lungs to noxious particles or gases. And I think the important part of this term is that it is not fully reversible. Some people still get COPD confused with asthma, okay? These are two totally different disease processes. With COPD, again, not fully reversible. With asthma, there is the reversibility in the airflow obstruction. Whom does it affect? I'll talk briefly about the epidemiology and the prevalence, as well as the economic burden, and also touch on the vulnerable populations. COPD is diagnosed using a spirometer. Has anyone ever performed spirometry? Okay, I see several hands out there. It is not an easy test. What spirometry is it's easy to perform in an office setting. And what we do here is we're measuring your air volume and flow. And these are, spirometry is actually part of a pulmonary function test. So if a physician recommends a pulmonary function test, spirometry is part of that. When we're performing spirometry, we're looking at two main things. The first thing that we're looking for is the forced expiratory volume in 1 second. And we measure that as a percentage of the total amount of air that can be forcefully expired during a 6-second period. This is the main way of defining what COPD is. So when we're measuring forced vital capacity, and I'm just going to give a brief description of what spirometry entails. I'll show you a picture. This is what a normal office spirometry looks like. It's performed usually by a respiratory therapist or a medical assistant. As you can see here, The person has the device, the spirometer, placed into his mouth. The airflow is measured through the computer, and we get this nice graph here that tells us how they're doing. Again, it's a closed system, so people are required to use the nose plugs to keep the system closed. But as you can see here, spirometry can be challenging. To ask someone to expire for 6 seconds, probably not a big deal, right? Because you can sit here and blow pretty quietly for 6 seconds and you don't get breathless. But what we ask for when we do spirometry, we have you take some normal breaths, we call it tidal breathing. You're breathing in and out. And then we have you take a deep breath in, and then our therapist is yelling at you to blow out the air as fast as you can. So you take a breath in, and then you blow out, and you blow out, 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 out for at least 6 seconds. And what we're measuring is the amount of airflow in the first second over the total amount of airflow. And the definition of what COPD is most people should be able to get 70% of that air out in the first second. If you can't get more than 70% of the air out in the first second, it could indicate that you have COPD. Okay, again, COPD is a chronic disease. It's prevalent, anywhere between 5 and 10%, depending on what diagnostic criteria are used. The third National Health and Nutrition Examination Survey data, they calculated, using spirometry, that there was a prevalence of COPD in adults of about 7%. So if we have a room of about 100 people, there will be at least 7 of you that have COPD. Again, fairly prevalent disease. COPD is responsible for 700,000 hospitalizations annually in the United States. In recent years, the hospitalization rates for women have actually increased and is now equal to that for COPD exacerbations among men. In 2005, more than 126,000 adults in the United States have died from COPD. As far as adjusting it for age-adjusted mortality, it differs dramatically by state. The lowest rate of mortality is in Hawaii, approximately 27 deaths per 100,000, and the highest rate is in Oklahoma, approximately 94 deaths per 100,000. This is from the CDC. As you can see here, the higher the death rates per 100,000 people, the darker the shade is. As we can unfortunately see here, West Virginia is one of the more prevalent states for deaths related to COPD. To me, a little surprising, but not fully surprising. I did some of my training in North Carolina, and North Carolina, of course, is like the home of cigarettes. I thought I would see the most COPD there, and surprisingly, North Carolina is just a lighter shade. But as you can see, there's a good belt here of high death rates with COPD, as well as up here. As far as the financial burden, it is estimated that direct medical costs in 2012 were approximately $30 billion. Indirect costs related to COPD, related to the morbidity, which includes work time loss and productivity, also results in $20.4 billion annually. So together, almost $50 billion annually related to the burden of COPD. It's pretty astounding that 50 billion, this is billion, it's not million, that's $50 billion related to COPD and its disease. to talk about the physiology and some genetic environmental influences. COPD comprises a collection of different processes. As I discussed, it includes chronic or recurrent bronchitis, emphysema, and there's airway responsiveness with COPD. Of course, the most important risk factor for COPD in the United States is cigarette smoking. So what does COPD look like? It looks like a lot of different things, and these next two slides are kind of showing to depict that there is no set look for COPD. COPD can look like anything. It could look like a healthy, young, white male that's middle age. He can have COPD. It could be a female who is Asian and fairly young. This lady here, this lady here looks nice and healthy. She obviously functions well because she's doing chores along her house. She could have COPD. And then you have the COPDers that smoke their whole life, and they can actually reach golden ages of 100. So COPD has a lot of different looks. It's not a typical look that a COPD person has. I do get a lot of comments that from patients or families that's saying, oh, that patient probably has COPD because they're bringing oxygen with them, and that's not necessarily the case. As far as genetic influences, one thing that we've found fairly common here in the Eastern Panhandle of West Virginia is alpha-1 antitrypsin deficiency. We do screen everyone with any type of airway obstruction for this deficiency, and the best thing is it's a free test. What alpha-1 antitrypsin deficiency is, it's an autosomal recessive disorder. That means that you have to get it from your parents, both parents. Okay, if you get the allele from just one parent, you won't have the disease, so you have to get the allele from both parents. What it can lead to is both lung and liver disease. So when I meet someone that I'm evaluating for COPD, I always ask them if there's any history of COPD, emphysema, chronic bronchitis, even asthma, because sometimes people were mislabeled as asthma, and they actually have COPD. I actually ask if there's any family history of liver disease, such as cirrhosis, because people with this deficiency can develop premature cirrhosis. Again, screening tests are available, and just briefly, treatments is what we do is we replace the enzyme that is deficient in the body. That's how we treat it. Age and gender. There is studies that suggest an accumulative effect, which simply means the sum of exposures throughout the life. But just because someone has smoked 50 years, are they more likely to have bad COPD versus someone that smoked 20 years? Not always, not necessarily. Again, there's genetic differences, but there are some studies that support that there is a cumulative effect with smoking. As far as prevalence, again, women are now equal to men with COPD, and that probably has a link to the changing patterns of cigarette smoking. Exposures to particles can also cause COPD. Again, cigarette smoking is the most common risk. Other types of smoking or tobacco, including pipe, cigar, water pipe, and marijuana smoke, are also risks for COPD. Passive smoking or secondhand smoking also contributes to COPD risk and increased symptoms. As far as environmental exposures, it's important that we keep in mind any exposures in the past to both organic and inorganic dust as well as chemical agents. These are underappreciated causes for COPD. Again, when we talk to patients, we usually ask what type of occupation you did, because some occupations increase your risk for developing COPD. Other things to think about, wood, animal dung, crop residues, and coal, when it's burned over open fires, they can create high levels of indoor air pollution. Again, probably more common in West Virginia than other states, so always something to think about. I want to talk about the symptoms. The main symptom that brings people in to see their primary care physician or that are referred to us is that people tend to complain of dyspnea. And what is dyspnea? Dyspnea is the cardinal symptom for COPD. And what dyspnea is, it's people that complain of a sense of increased effort to breathe. They complain of heaviness. They complain of air hunger or gasping. Okay. Some people use shortness of breath. I've been short of breath. But a lot of people say, in one of these terms, it's heavy to breathe. I find it hard to breathe. I have a hard time taking a full breath out. Those are the symptoms of dyspnea. Another common symptom is cough. Cough can develop at any spectrum within the COPD. Initially, it's usually an intermittent cough, but later on, it becomes present every day and usually is present throughout the day. Sputum production. A lot of patients with COPD commonly raise small quantities of thick sputum after coughing. People with chronic bronchitis tend to bring up the phlegm early in the morning, and they say they feel better and cough up less as the day progresses. That's what the typical presentation of chronic bronchitis COPD is. Regular production of sputum for 3 or more months in 2 consecutive years is the actual definition for chronic bronchitis. Some people have wheezing and chest tightness, and these are nonspecific, but they do occur throughout the day. So chronic bronchitis, again, is a major component of COPD, and it does consist of bouts of increased cough and sputum production that occur frequently. The attacks may be related to either acute bacterial or more commonly a viral infection. And this is a chronic process, and sometimes it leads to premature damage of the airways and what we call bronchiectasis. Okay. While most people have bronchitis at some point in their life, recurrent episodes, usually 2 or 3 per year, are observed in COPD. I usually like to ask, how often do you have to call your physician or go to an urgent care center or emergency room for people with COPD, because what they're having is a flare-up of their COPD. As far as emphysema is concerned, again, there's destruction of the air sacs in the lungs, and a result of the disruption of intake of oxygen and the elimination of the toxic gas, the carbon dioxide. Question? Yes. The pulse oximeter? Yes. Yes.
If you have COPD, well, is that a way to see if you have it?
For people that have more of the emphysema type disease in the spectrum of COPD, there could be an indication that you're not having adequate oxygen flow to your fingertips, and that could indicate COPD, but it can also indicate other diseases as well. Yes. As far as physical exam is rarely diagnostic in COPD. Again, there's not the typical picture of what a COPD patient might look like. Physical signs of airflow limitation are usually not present until there's significant impairment in lung function. A number of physical signs can be present in COPD, but their absence does not exclude the diagnosis. This is what a chest x-ray looks like of emphysema. I've had some people come to me saying that the x-ray said I have emphysema, or the emergency room doctor told me I have COPD, and I've never been told that. And this is what they're looking at when they're told that you probably have COPD. The thing to appreciate here is the volume of the lungs are big. People have big lung volumes. What happens is the lung tries to compensate for what it normally does. So the lungs are compensating. It's trying to help force the air out, and you have an expansion of the volume of the lung itself. So when people say you have COPD based on your chest x-ray, this is what they're looking at. I don't like to call people COPD based on a chest x-ray. We use spirometry for that. As far as classification is concerned, these are the guidelines that we use for treating COPD. Again, what we're looking for is that ratio less than 70%. As you proceed from a mild to a more severe case of COPD, what this classification is based on is the amount of air that you can force out in that first second, okay? So if you're getting more than 80% out of the air out in that first second, you may have mild COPD, okay? As you can see here, the amount of air forced out in the first second becomes less. The severity of the COPD becomes worse, okay? And this is how we typically classify how bad someone's COPD is, okay? So we go from mild to moderate to severe to very severe. And again, this is based on these numbers here. As you can see, moderate is from 50 to 80. Severe is from 30 to 50. And then very severe is usually less than 30. This also includes how we tend to treat people with COPD. Again, we use inhalers, short-acting bronchodilators as needed. And as you can see here, we prescribe those for people whether they have mild or very severe COPD. We usually recommend people to get vaccinated with influenza vaccinations and, if appropriate, a pneumonia vaccine. As the disease progresses, we start adding therapies. We start adding bronchodilators that last a long time, as opposed to the short-acting bronchodilators. Sometimes we start recommending pulmonary rehabilitation. Again, this probably depends on how functional someone with COPD is. Just because you have moderate COPD versus very severe COPD, this person may perceive to be more functional than this person here. What we usually do in patients with severe COPD is we add inhaled steroids, and that's to treat the exacerbations related to COPD. And as we get into the more severe cases, we start thinking about long-term oxygen therapy and sometimes surgical interventions. The thing that is important with the different stages or classifications of COPD is that the more severe, the more likely one will get ill and increase their risk for hospitalizations and recurrent illnesses. And that's why we like to classify what stage of COPD you are. The thing about COPD, increasingly associated with other diseases such as pneumonia, hypertension, congestive heart failure, other forms of heart disease, lung vascular diseases, cancers, osteoporosis, and depression. As far as prevention is concerned, we always want to prevent the disease before it happens. And the primary prevention is to try to avoid smoking of any sort, try to avoid exposure to things that can cause COPD. What I think is very important is that we prevent teenagers from starting at an early age. So if someone is smoking and in front of their kids, niece, nephew, that does have an influence on what they see. If they see an adult smoking, they're saying, well, if they're smoking, that's probably not that bad of a thing. So I think primary prevention, preventing teenagers from smoking, is clearly important. We like to get people that are smokers to try to stop as well. And there are many strategies, including public campaigns, personal counseling, higher cost of cigarettes, which actually has helped some, and also new medications. Secondary prevention aims at detecting the disease when it's still relatively mild and treatable. I have, as a pulmonologist, I have a very low threshold to order a spirometry test on you, okay? Because I like to know about a disease when it's still fairly mild. Unfortunately, for me, as a pulmonologist, I do not get to see people until they're severe COPDers and are fairly symptomatic. So I try to encourage primary care physicians to order these spirometry tests. Again, they're easy to perform, they're quickly performed, and they help detect the disease early. Secondary prevention has been found to be helpful in cardiovascular disease as well as diabetes, but the verdict is still out with COPD. I don't really feel that way. I really feel like if the earlier we detect the disease, the more we are able to treat you, whether it's to get you to stop smoking or to start you on appropriate therapy. As far as treatment of COPD is concerned, first and foremost, and I think we're seeing a theme here, is that you have to stop smoking, okay? Again, it is important for you to talk with your primary care physician about trying to stop smoking if you can't. I think it is, if it's not talked about, it won't be addressed. Most physicians are good about asking the question. Sometimes, if you have a 15-minute block to cover a lot of different illnesses, you may forget to ask about their smoking habits. So mention it to your physician. Don't be afraid. Tell them that you want to stop and how can you help me. Counseling has been proven to be effective, so I encourage everyone to talk to your physician or healthcare provider about smoking cessation. What we do use is nicotine replacement therapy. These come in different forms. There's nicotine gum. We use nicotine inhalers. That's kind of funny. We use nicotine nasal sprays. And I think probably the most common thing that is used for people that try to stop are the nicotine patches. We do use pharmacologic therapy as well. I usually don't like to prescribe these unless patients are absolutely willing to stop smoking. If there is any hesitancy or reluctance to stop smoking, I stay away from these type of medicines. People have to be ready to stop before you start spending these type of monies on these medications to help you stop smoking. I tried to not put the brand names, but I think the brand names help because nobody really remembers the generic names for these medicines. probably the two most common used medicines for smoking cessation are Chantix and Zyban. Studies show that there are quit rates anywhere between 30 and 35% when used with other means, which includes nicotine replacement therapy or counseling. Inhalers are a big part of treatment of COPD. They come in different styles: bronchodilators, steroid inhalers, and combinations. For patients with stable COPD, and if you could remember back to the staging of COPD, the people with mild or even moderate COPD have stable disease. What we like to prescribe are these quick relief inhalers. These you've seen them all. They're little inhalers that you carry in your hand. You can put in your pocket. You can put in your purse. They also come in nebulized forms as well, which probably have easier delivery. If any of you have gone to an urgent care or emergency room for shortness of breath, you've probably been treated with a nebulizer of some form. These bronchodilators, these are the names of the most common bronchodilators. Albuterol is a generic name, but I also included these names here because sometimes I ask people if they're on albuterol, and they say no, I take Ventolin, and they're all the same thing. They just have different names, and that's based on different manufacturers. Ipratropium bromide is another one, also known as Atrovent. And then you have a combination of the two, and that's wisely called Combivent. Okay. And these work to dilate, open up the airways. Again, prescribed for all stages of COPD, mainstays of therapy for the milder form of COPD. We have maintenance therapy, and these are to be used on a daily or twice daily basis, no matter how you're feeling. Again, sometimes people are feeling fine. They're using these inhalers every day. They stop using it because they're feeling fine, and before you know it, they're experiencing shortness of breath. These inhalers aren't meant to work that way. Again, they do not act quickly, but they have longer effects. These inhalers include long-acting beta agonists, which are your long-acting albuterols that were on the previous slide. Again, these come in inhalers and nebulizers. What they include are these three different ones: formoterol, arformoterol, and salmeterol. And again, used for COPD, not used for asthma. And that's the difference between the two disease states. Again, these work by dilating the airways, but these last for 12 hours and longer. Okay. And then we have the long-acting anticholinergics, also known as the Atrovents or the ipratropium bromides, as you saw on the other slide. Again, these come as inhalers, and these are the two most common ones. You've probably come across Spiriva in some form of another, the commercial with the elephant sitting on the man's chest, that one. And then the newer one is this one here. Okay. We use inhaled steroids. Again, if you can recall back to the different stages of COPD, inhaled steroids are more so for the patients with moderate or severe disease, or patients that have recurrent bronchitis and have a lot of sputum production. Inhaled steroids work on the inflammatory component of COPD, and they come in inhalers and nebulizers, and these are the most common ones that are used. And the pharmaceutical companies became smart, and the research became better, and they combined the two things, the bronchodilators and the steroids, and they put them in one inhaler. And this is a result of the combined inhalers, usually used twice a day. And again, they have a steroid and a bronchodilator. This one down here is the latest. It's called Breo, and that one is used once a day, amazingly. The thing that I've come into recently is that I've been practicing for almost 11 years now. Probably the first 6 years of practicing, we had a handful of medicines. Probably in the past 5 years, they've probably developed twice as many as those. So there's more research going into COPD, and as a pulmonologist, I find that encouraging. Okay. Some of the other therapies that we use, there's this medicine here called Roflumilast. This is a pill that you take once a day, and this works to dilate the airways, and it also helps to decrease the mucus production. An old medicine we use is called Theophylline. It's also used in asthma, and this has similar effects to this medicine here. We do use steroids. We try not to keep people on steroids chronically because of the side effects associated with it. And there are also a lot of studies supporting using chronic antibiotic therapy for people with COPD. As far as acute therapy, and by what I mean by acute therapy is you're feeling sick, you're coughing, you're short of breath, you have to go to the emergency room or to an urgent care center. And you usually get treated with steroids, usually intravenously. They usually give you antibiotics. They usually put you on oxygen, and they give you a breathing treatment. And a lot of these are just acute phases performed to hopefully prevent you from being hospitalized. Okay. Again, these are the treatments: nebulizers, oxygen, and pulmonary rehab. We have an outstanding pulmonary rehab program here at the Wellness Center. If any of you all are interested, they do a great job. I've had a lot of good feedback from them. As far as tertiary preventions, and with tertiary preventions, you try to lessen the complications associated with the disease. Again, we treat them. We treat people with the bronchodilators, the anti-inflammatories, and the antibiotics. What we're trying to do is to reduce the exacerbations of the disease and to prevent the accelerated decline in function. Again, we recommend influenza and pneumovax vaccines unless you have an allergy. And some people just don't believe in vaccines. These are some websites that you may be interested in. They have a lot of good data about COPD and lung disease in general.
Please join me in thanking Dr. Aguilar for a great lecture this evening.
Thank you.